Okay.
And
Uh, so this is Achinta, a 12-year-old boy who's from Kurnagal, currently in grade 7, and the history was taken from the mother, who is a housewife, educated up to O level, and not very well educated about the condition. This child presented, uh, this child presenting complaint is that he was admitted following a UFR finding of increased red blood cells in urine during a clinic follow-up investigation. Uh, so regarding his history of presenting complaint, uh, I would like to start from his past medical history. Uh, 4 years ago, initially, this child developed fever, and during this time, the mother noticed that the child was starting to get several patches of bluish discoloration in his legs bilaterally. Thereafter, the child was taken to the hospital and was investigated where a full blood count showed very low platelet count. Thereafter, he was admitted in the hospital for a week, during which the febrile illness was treated, and he was also started on a course of prednisolone, with the initial dose being 20 milligrams. Um, Again, 2 years later, the child got a similar episode with fever and similar rash, but throughout his body. And during this time, they were away from Kurunagala, so they went to the hospital where they were at, and due to lack of resources, they were uh, transferred to Lady Ridge Hospital. And once again, he was treated with a course of prednisolone, and more investigations were done, which include skin biopsy. And due to poor healing of these lesions on the legs, they even had to do surgery to remove these lesions. And this was his second episode. And thereafter, he had been on follow up till the current presentation. At current presentation, he was off prednisolone for around 5 months. And once he was started, once they found out that he has uh, been losing red blood cells in urine, they started him again on a higher dose of 40 milligrams. Uh, he never had any episodes of epistaxis, gum bleeding, or uh, abdominal pain, bone pain, and no headache with vomiting and altered level of consciousness. That's regarding his history of presenting complaint. And regarding his uh, past surgical history, he did not have any surgeries done and no splenectomy other than the surgery that was done for the removal of these lesions. Regarding his allergic history and drug history, he has a drug history for which the mother does not which the mother does not know of during his initial treatment. And there are no food or plant allergies. And he, regarding drug history, he's on prednisolone. With regards to his birth history, he had a normal vaginal delivery at term with a birth weight of 2.6 kilograms, and the antenatal and postnatal periods were uneventful. Immunization history is up to date, with the last vaccine being taken is the adult tetanus uh, and diphtheria vaccine. Uh, Regarding his development history, it's age appropriate, and he gets on average around 60 marks in school, and he takes part in physical activities which such as sports in school. Um, Regarding family history, there is no significant family history of any bleeding disorders, but his brother has a convulsive disorder for which he is on medications. And social history, he lives in his own home with his mother and great grandmother and brother. The father is a freelancer who is working in Kalambu, and but the mother does not know about his income. But she complained of poor financial stability and poor extended family support as well. The closest hospital to them is 10 minutes away, which in Kunagala, but they don't own an own vehicle for travel. Um, See, that's all regarding my history.
Okay. Then growth, sorry, examination.
Okay, on examination, his height was 146 centimeters. Weight was 45 kilograms. See, for this, I couldn't get the standard deviation because, like, he's 12 years old.
Now,
That's
BMI.
what I did not calculate the BMI.
Okay.
Okay. And on general examination, he was comfortably lying in bed. He was afebrile. There was no pallor or icterus or clubbing or ankle edema. But but I noticed surgical scars on his legs. On CVS examination, his pulse rate was 96 beats per minute. On chest inspection, there was no visible chest deformities or pulsations. On palpation, his apex beat was felt in the fourth intercostal space in the midclavicular line, and there were no any thrills or parasternal heaves. On auscultation, uh, dual rhythm was heard and heart sounds were normal. On respiratory system examination, again on inspection, there was no unequal chest expansion and no chest deformities. On uh, palpation, expansion was equal in all three zones, and on percussion, uh, the lungs were resonant, and auscultations, lung sounds were normal in all three zones. On abdominal examination, uh, on inspection, there were no visible scars, dilated veins, or distension, and on suppression and deep palpation, there were no regions of tenderness or organomegaly identified, and on auscultation, bowel sounds were normal.
Neurology.
Uh, I did not do a neurological examination.
Okay. Uh, okay. What is the diagnosis? You said ITP.
Yeah, it's ITP.
Then what was the lesions that was difficult to remove?
Yeah, I this is what the mothers told me, and I don't really know what those lesions are.
Mm. Okay.
Wait,
Anything like C and cow, P and cow, anything like those investigations were they done at any
no,
point?
the mother did not know about any of those investigations.
Haven't they done a bone marrow?
I told her, I mentioned about bone marrow biopsy and skin biopsy.
Ah, both were done, no?
Yeah,
So the diagnosis is ITP, nail.
yes.
Okay. Now, other thing is like the presenting complaint. What is the presenting complaint?
Presenting complaint was admitted following UFR findings of increased red blood cells during a clinic follow-up in urine.
Uh-huh. Okay. So, why do they routinely do these things?
Not sure why he did it. Like, I'm not sure about that.
Now, usually, like, why I'm asking, like, why would they routinely do a UFR in a child with ITP? Hima, like, we do really like routinely we don't do neither.
Uh-huh.
There's no indication to do the UFR in ITP child unless they have hematuria.
Yeah, I
Yeah, so okay. So let's forget about the presenting complaint. So now let's say you are getting a child with fever and rash, right? Bluish discoloration.
mhm,
Like if we were to take the presenting complaint of the very first episode, fever
mhm.
and rash, which occurred around 4 years back. What are the differentials that you would consider at that point?
At that point, uh, it could be a fever with rash due to other causes.
No, these are bluish discolorations. No, let's forget fever with rash and we will go with the like these are bleeding patches, ni, ecchymotic patches. No,
Yeah. Uh,
so what would be the causes?
so we can have yeah, ITP is the one differential.
Okay,
Uh, Hemophilia.
why would you get fever in hemophilia?
Sorry, HUS.
HUS, you don't get Hemolytic urine syndrome. Yeah. Okay. Okay. Not not on the top of the list, but yeah. Then
Mm.
okay. Now, like it's like this. Now, if this is a like a bleeding, like a possible bleeding condition, right? So now, first of all, we need to know what are the things that can cause bleeding in a patient like this. So, like, if just forget the fever. Now, if we take bleeding per se, bleeding will occur if there is some problem in the clotting profile. So
Mm.
clotting will occur. Clotting for the clotting pathway to occur, there is a vascular vessels also play a role. The clotting, the whatever the uh, factors play a role, and platelets play a role. So platelets can be abnormal via means of the number, that is the quantity and the quality. So they can be having a thrombocytopenia or any other functional thrombocythemia. Then the vessels, they can be friable, and all these things can occur in senile purpura, and also you get that it's curvy and the other collagen vascular disorders, right? And then the coagulation profile can go wrong in different conditions, like you all know about hemophilia, Christmas disease, right? So and so many things. But now for the long case, you will not be getting time to analyze each and every condition. So apart from the things where the clotting can go wrong, so other thing that you need to focus is, now this patient is having a bleeding problem. But you also need to know whether the patient is having, along with the bleeding, events of bleeding, whether the patient is having any other manifestations of leukopenia or anemia. So concurrent leukopenia and anemia is there or not, you need to differentiate, and that has to be mentioned early in the history, right? So let's see if this patient is having a pancytopenia with anemia and neutropenia, leukopenia, and thrombocytopenia. Then one of the differential that you will need to consider would be acute lymphoblastic leukemia.
Mm.
Okay.
Mm.
So in that sense, the patient, if it is an acute condition, you will not notice that many recurrent infections. But if the patient comes with fever and multiple ecchymotic patches, and then one of the differential that you have to keep in mind is this acute lymphoblastic leukemia. Okay.
Yes. Okay.
Okay. So then other things, other causes of bleeding. So they are like, if the ALL, like if it is a late diagnosis, you can, in the history even you can ask about getting recurrent infections. They might be getting simple infections, but it will be occurring recurrently, right? Like a simple multiple episodes of pharyngitis, lower respiratory tract infections, those sort of infections will occur if the child is having a leukopenia, right? And then they can be having associated anemias, especially if there are conditions like Evan syndrome, right? In Evan syndrome, you have a ITP, and along with that, you have an autoimmune hemolytic anemia, right? So then in Evan syndrome, you will have those features. So you will need to ask about the anemic symptoms from the in the history, right? Especially with regard to the very first episode, you have to ask about the anemic symptoms like shortness of breath, lethargy, easy fatigability, right? Those symptoms have to be asked in the history, right? Now, so like a lot of differentials are there, but for the sake of the long case, you don't need have time to ask everything. No, in the long case, there's limited time, so you need to have the prioritized list of differentials that has to be asked in the patient like this. So one thing would be acute lymphoblastic leukemia, and you did mention in some points towards that, like they will get the features of anemia. You can ask the features that I mentioned, any recurrent infections, and they will have a fever, right? Some might get high fever, but majority will try to get this evening pyrexia, sort of a low grade pyrexia. And also they get the bone pains, right? The typical nocturnal bone pain, right? That will be there in these patients with acute lymphoblastic leukemia. And like you mentioned, the child was having fever but fever for how many days? That is important, because one of the other differential that you need to worry is the dengue, right? So the child can be having dengue with tender hepatomegaly, right? Vomiting, and these all the other seven classical features of dengue. You can ask to exclude dengue in the history. And the other thing is, like especially in a child like this who is having a you said some epilepsy syndrome is going on in the family, right?
Yes,
So
yes.
in that case, the child, if this child has accidentally taken sodium valproate from the sibling, right? So then sodium valproate can cause thrombocytopenia. Not only valproate, there are other things like phenytoin, valproate, the sulfur drugs, right, including cotrimoxazole, they can cause thrombocytopenia. Then, like you said, HUS is another thing, but HUS should not be mentioned in the top because with HU, for you to tell HUS, the child should be having blood and mucus diarrhea. Along with that, there has to be features of evidence of acute kidney injury, right? Should be having reduced urine output, fever, fits, and anemic symptoms, right? So all these things have to be mentioned for you to tell it is HUS. Another thing
Mm.
that you can tell is apart from acute lymphoblastic leukemia, these things are the maker, SLE, right? So you
Mm.
can talk about, because even ITP can be like one of the manifestation of SLE also. Okay,
Mm-hmm.
so if you were to tell, you can talk about these small joint pains, right? Again, the constitutional symptoms, painless oral ulcers, non-scarring alopecias. Then they will have a photosensitive rash in this face, right? And nasolabial fold sparing. Those things can be mentioned, right? And the other very most important thing that should be mentioned is this non-accidental injury. So that has to be highlighted in your social history, whether this child, how is the environment, is there anyone who is taking care of the child, right? So non-accidental injuries, like especially if this child was like a bit younger than this, then non-accidental injury has to be considered in the top of the list. Okay, so those are the top differentials that you need to consider. Okay, are you clear on the differentials, right?
Yes.
Yeah, so these differentials I mentioned was for the ITP long case, right? Now, if like for any if there's any other person with ITP, like if you're thinking, but then you have to go in the order, like you have to rule out each and every possibility, like each and every functional disorder of platelets, quantity like thrombocytopenias, right? Vascular defects and all the coagulation profiles you can do, whatever the mixing studies and all that you can do, and rule out the, like if you were to clear the entire list of differentials for the bleeding disorders, you can go do it like that. But for the sake of the long case, these are the top differentials that you need to rule out, right? So
Mm.
acute lymphoblastic leukemia, dengue, drugs, SLE, HUS, and non-accidental injuries. Those are the top differentials that you have to rule out, right?
Event
So,
syndrome.
sorry.
Event syndrome.
Yeah, event syndrome is again like yeah, you can rule out, but it is not like a top differential, right?
Okay, okay, okay.
Okay, right. So, okay. Uh, Okay, right. Then, okay, now, okay, so after telling this history of presenting complaint for the this part, now you have to tell this. Now, if I were you, like, let's see now, this patient, most of the time you won't get a patient who is coming from the very first episode of ITP, right? They can be like a clinic patient or someone who has come to the clinic, and then they will call for the exam, and then only they will be there. No? So you
Mm.
need to go back and tell this is a patient who is diagnosed patient with a hematological condition, right?
Mm.
Relapsing and remitting hematological condition for which they are attending the clinic regularly, and this time has attended for a routine clinic follow up, right? So because it is relevant, I would like to start the history from the very first episode. Kira, you go there and then you start analyzing the history. So the differentials have to be told in regard to the very first episode, right?
Yes.
Not to the current episode. No, so there's nothing even in history. I'm not really clear about the present income plane also,
Mm-hmm.
right? So you have to analyze the first one. So you have to, one thing would be to rule out the differentials, right?
Mm-hmm.
So then after that, you need to also tell about the other possible etiologies that are considering, right? So other etiologies in the sense, now most of the time the ITP it is idiopathic. So because it like idiopathic here, like there is no cause, right? You don't know whether there is a cause is there or not. But the secondary causes are there. Like one thing was SLE, we mentioned. And the other viral infections are there, like cytomegalovirus, varicella, hepatitis C, HIV. Those sort of viral infections can cause ITP,
Mhm.
right? And even Helicobacter pylori, that's a bacterial infection that can also cause ITP. And any other lymphoproliferative disorders, they also can cause, like whatever the malignancies, they can cause ITP. That is the main reason why this child has had a bone marrow biopsy, right? Otherwise, you don't need a bone marrow biopsy, no. So
Mm.
these different etiologies, like you have to address in your history of presenting complaint. Then comes the most important part, that is the complications of ITP. So one of the most important killer, right? The principal cause of death in patients with ITP is ICH, right? So how will they present with like ICH presentation? You correctly mentioned. So they will present with altered level of consciousness, vomiting, headache, even seizures, and any other focal neurologic deficits will be there. Okay.
Yes.
And these patients will try to bleed from whatever the other possible signs. So from the GI tract, they can bleed. So they will come with melena, right? So if the upper GI, they will have a lot of mucosal bleeding, right? They can also get abdominal pain, right? And also they can get multiple muscle hematomas following IM injections, right? And then the other complications are, because these, if the patients become severely anemic, they might end up getting blood transfusion. So you have a whole lot of transfusion related complications, transfusion transmitted infections, and other complications that can be mentioned even for these patients with ITP, right? So now for the from like those things also have to be told in the HOPC. Okay. Now let
Mm.
me remind you again. So you started with the first attack and you mentioned how it started, right? From there you ruled out all the possible differentials, right? And complications has to be like ruled out throughout the course of ITP. And you have to tell how many episodes, right? How many relapses has the child has had so far. Then you have to tell the frequency, because we need to know whether this condition is getting like how the control of the child. So whether it is like how is the control going, like whether it is infrequently relapsing or frequently relapsing, like that picture you have to get, right? If you have a timeline, then it will be very easy to give the relapses, right? Then you have to tell how long the patient is on. Now you said the patient is on steroids, but you did not tell any steroid related complication, right? So that day I
Yes.
told no,
Yeah.
there is
Yeah.
a yeah, there was a mnemonic cause. I told you.
Yeah.
So MEBG or something. So metabolic, you have polyphagia, obesity, diabetes, dyslipidemia, hypertension. Those things comes under M. Then E is for eye, where you have posterior subcapsular cataracts. Then B is for, I think, I also can't remember this, bone or something, right? They get the osteoporosis and all that. So, and G is for gastritis, right? So those sort of keep a mnemonic, and whenever a patient is on prednisolone, don't forget to ask the complications of steroids, right? And then if the patient has changed now, because the chronic ITP patients tend to be on multiple immune suppressants, they can be on IVIG, they can be on dapsone, they can be on azathioprine. Those sort of immune suppressions are there. So you like you did, like this mother didn't know a single drug, that's a different story. But if the mother knew the medications, then you could have told about the like how the drug chart has evolved with time, and what if there are places where the drug chart has been changed, you can tell them, give the reasons for changing the drugs as well, right? And this, because this child is an older one, like 12-year-old, you can tell about the plans for splenectomy. You did not, you told in the past surgical history that the child, they have not done a splenectomy, that is very correct. But you have to also tell whether the child was received the pneumococcal meningococcal vaccine, right? Any
Oh.
plans of continuing the penicillin prophylaxis. So those things can be brought up to your vaccination history.
Mm.
Okay.
Mm.
And the other thing is, right. So Okay, so then examination was fine. But then in the general examination itself, you can tell about any other obvious bleeding sites, ecchymotic patches. I think you mentioned about ecchymotic patches, but you can tell just to give the examiner the idea that you inspected the oral cavity. You can talk about the oral cavity, the nasal polyps, and then because those are the places where they tend to bleed a lot, right? And
Mm.
you can even offer a DRE to this kid, right? Because to rule out melena, right? Offering a DRE will be very helpful in this one. And also, like even you can tell the like abdominal. The thing is, abdominal examination has to be mentioned first, right? So you did it as the second or third system. No, that has
Yeah.
to be mentioned in the first, and you have to talk about the peripheral stigmata of CLCD because CLCD also causes thrombocytopenia because of the sequestration due to portal hydration, which again can lead to thrombocytopenia, right? So sorry, which again can lead to bleeding. Okay, and then you have to talk about lymphadenopathy in detail, right? Was it mentioned? I can't remember,
No, I did not
right?
mention lymphadenopathy.
Yeah. So you have to even tell, like, spend a little bit time on lymphadenopathy, even tell there is not even epitrochlear lymph node or something you can tell, right? And in the general examination, you have to also talk about the peripheral stigmata of any other autoimmune diseases, right? So you can tell non-scarring alopecia, whether there's any episcleritis or scleritis, right? Because scleromalacia perforans is another complication in rheumatoid arthritis. You can talk about any eye redness in the eyes, and then you can look at the oral cavity with regard to autoimmune condition like painless oral ulcers, right? So they get this geographic tongue, right? And then you can talk about a malar rash, right? And those kind of peripheral stigmata for autoimmune diseases also have to be mentioned. And doing the CNS examination is mandatory in these kids because you have to assess the, at least you could have mentioned me about like GCS, right? How is the bilateral pupillary reflexes and all that, and the deep tendon reflexes, the fundus, those things have to be mentioned. Okay, right. Now, so about I will tell a little bit of theory about ITP because we like ITP is not a very common thing to get in the exam. So I will tell a little bit of theory about ITP before going on to the investigations. Now you know what happens in ITP is it's a immune mediated disease, right? What happens is these platelets get coated with the antibodies that are generated in the body itself, right? So once the antibodies are there, so the antibodies have this FC receptor component. No, so these antibody coated platelets, they are these FC receptors. They get signals from these splenic macrophages. So then only these antibody coated platelets get phagocytosed by the macrophages, and then they get destroyed. This is the main principle behind giving the anti-D, right, Rogam to kids with ITP. So when you give Rogam or anti-IG, anti-D immunoglobulin to the kids, now let's say you have a positive blood, and I am giving you the anti-D, right? That anti-D then what will happen is, like in proportion of your red blood cells, these artificial anti-D will go and get attached. So these ones will go and occupy the macrophages that were previously engaged in destroying the platelets. So temporarily you will get a hemolytic anemia. That is true, but your ITP will be cured up to some extent by giving the anti-D immunoglobulin. Okay. And the other thing is ITP, acute ITP mostly occur in children and they don't have a sex predominance. Like male, female, it is the same. But chronic ITP is the one that occurs mostly in the elderly where there is a female predominance. Okay, did you get it?
Yeah.
Okay. Then other thing is, you mentioned about the etiologies. Etiologies I mentioned under the etiology calendar. So most of the time, for you to tell it is ITP, they should be having isolated thrombocytopenia, right? That is why you need to rule out the any symptoms like with regard to neutropenia, any symptoms with regard to anemia. You have to rule them out, and you have to tell this is a isolated thrombocytopenia. Okay, right. Now, if it is an acute ITP, it is a self-limiting thing. You don't need to do anything, and it will run over in about 1 to 2 weeks period. But if it is a chronic ITP, most of the time the exams they will give the chronic ITPs, they will have this relapse intermittent course. Other thing you have to rule out the event syndrome. I told you, right? So and then you have to plan the investigations and management for the patients with chronic ITP. Now, let's say you get a patient with a bleeding tendency. What are the investigations that you would do?
A full blood count.
Okay, and you have to tell me the reason also. Why would you do?
To look at the platelet count and or do a coagulation profile to check the clotting
No,
factors.
no, 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 no. I mentioned also so full blood count. Now you have a patient with fever and multiple ecchymotic patches, and I am asking like the investigations. So you will do the full blood count, and you will look at all three cell lines, right? So then only you will have the idea this is an isolated thrombocytopenia. Before that, you don't know. No? If it
Yeah.
is there anemia, it can be events. If there's a pancytopenia, might be heading into a either like we don't know whether it is a ALL or Fanconi or whatever, right?
Yeah.
Okay. So then after full blood count, mention the blood picture, right?
Okay.
So in the blood picture, what would you see?
But picture.
Hmm?
Are we looking for any blast cells that to exclude
Yeah.
AL?
That is great. Yeah, that is what. Right. So we will check for the presence of blast cells, and you can see some increased megakaryocytes, right?
Mm-hmm.
That also can be seen. Okay, then what else?
Do a coagulation profile
Okay.
to look for
No,
co-
no, no. You tell what are they are in the coagulation profile?
uh, PTINR
Hmm.
and APTT,
Hmm.
bleeding time.
Bleeding time, it's not in the coagulation profile, name.
PTINR, APTT.
Yeah, those two are the ones that are done in the May that will be enough. And you can also do the fibrinogen and thrombin time you can do. But other two will be enough. Okay. Then go on. Any other investigations?
Investigations.
Yeah, those are the basic investigations. And apart from that, you need to do the investigations to find out the secondary causes of ITP. Now, this ITP can be because of a lymphoproliferative disorder. Therefore, you can do a bone marrow, right?
Okay.
And if there are lymph nodes, you can even do a lymph node biopsy. And also, like if the child with ITP is going to get steroids, steroids can mask the diagnosis of acute lymphoblastic leukemia. So after steroid therapy, because they can even go into remission for a few periods, right? Therefore, you can do a bone marrow biopsy to rule out ALL also. And the other secondary causes has to be excluded. So one thing is the connective tissue disorders. We were concerned about SLE. So you can mention ESR, ANA, double-stranded DNAs, right? Other anticardiolipin antibodies, lupus antibodies can be done, right? And we were worried like why this thrombocytopenia is occurring. So you can do the liver functions to check the status of any CLCD or something, right? And virology screenings can be done. So we mentioned hepatitis C, cytomegalo, those HIV viruses. So you can do the appropriate viral screening for these. And you can do ultrasound scan abdomen to check for hepatosplenomegaly, right? Portal hypertension. Those things can be done, right?
Yes.
Okay, so are you clear about the investigations? Are you clear up to investigations? Are you clear?
Yes.
Right now, for each and every patient, you don't need to do every investigation, but like you need to have an overall picture about the investigations that you are going to do, right? Okay. Now, if it is ITP, once you do the bone marrow, you will get the megakaryocytes in the marrow, right? So Like I mentioned that, no? Okay. Right. Now, what are the management principles in patient with ITP? Hello?
Yeah, yes, please hear principles. We need to treat this current episode of bleeding.
Okay, let's say now this patient is admitted with fever and multiple ecchymotic patches. And let's say the patient's, okay, now forget the ecchymotic patches. Now let's say the patient comes with uh, no fever also, and you have randomly done a full blood count, and somehow you have found out the patient's platelet count is 50,000. What will you do?
Uh, 50,000. We just found isolated thrombocytopenia. Like we have come to the diagnosis of ITP right now.
Yeah, diagnosed patient with ITP, now coming back to the clinic with a platelet count of 50,000. No symptoms. Not
Wait,
on any drugs.
supportive management.
Yeah, actually, there's no management, right? Because the patient is asymptomatic.
Yeah.
So, here, what you need to know is the main goal of the treatment is to achieve that the platelet count should be a one that is adequate to have hemostasis. So, your treatment goal is not to achieve a normal platelet count. So, it is to achieve a
Mm-hmm.
platelet count that will be sufficient for a hemostasis, right? So roughly a platelet count of 20,000 cut off negative year, that is enough. Okay.
Mm-hmm.
So if the platelet count is more than 20,000, you don't need to admit or do anything, right? But like if the platelet count is getting less than 20,000, then you will need to admit these patients, right? Right. So when you have the principles of management, I usually divide it into four. One thing would be the patient education. So patient has to be mentioned about the what the condition, right? What are the complications, and what are the medications, and what are the expected things. Those all these expected side effects. Those patient education is one of the key things that has to be addressed, right? And even
Mm-hmm.
before that, any life threatening condition has to be addressed first, right? Then comes the patient education. Then comes the important general measures for ITP. So, what are the important general measures? So, these kids, they should be having some precautions now. So, you need to avoid NSAIDs, aspirin, and contact sports. Contact sports was not mentioned in the social history, right?
Yeah.
Contact sports and any risk of trauma like falls risk in the house you have to tell, right? So like may threatening staircases or staircases without rails you can tell, right?
Mm-hmm.
And avoiding IM injection is another general measure. And some of them are given tranexamic acid to be kept at home and taken whenever that is needed. But the problem with tranexamic acid is if you give tranexamic acid while they are having a hematuria, then they will get a obstruction and that is going to be a problem. Okay.
Mm-hmm.
And the other thing is proper oral hygiene. That also has to be mentioned as a general measure. Okay. So they have,
Right.
I told, five general measures: avoiding NSAIDs, aspirin, avoiding contact sports, avoiding IM injections, and adding an antifibrinolytic treatment and proper oral hygiene.
See
Right?
why? Why proper oral
Because
hygiene?
they can't go to the dentist now. They will bleed now.
Ah, okay, 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 okay.
Okay,
Yeah.
so that is the other thing. Then comes the so after the general measures, you need to tell a little bit about the pharmacological management. So when you're telling pharmacological management, don't go and tell platelet cutoff because some say the platelet cutoff is 20,000, some say it is 30,000. So you roughly have an idea. It is somewhere between 20 or 30,000. That is fine, right? So more 80% of these patients with ITP they will respond to prednisolone, right? So that can be offered as the first line treatment. So you give around 1 milligram per kilogram. You don't need to know the dose,
Mm-hmm.
right? And you can even reduce the dose in about 10 to 15 days, 14 days. You can reduce the dose,
Mm-hmm.
right? So then if you are not So if you want to if you want to continue the steroids for a longer period, you can even start a steroid sparing agent like azathioprine. Okay,
Mm.
that is the other thing. But if the patient is steroid resistant, right, even after 3 months of steroid therapy, you can go offer the splenectomy to the patient, right?
Mm.
And the other immune suppressive medications you need to know, like cyclophosphamide, azathioprine, which was previously mentioned, and immunoglobulin. I told about the immunoglobulin,
Mm.
right?
Mm.
And the fourth important principle is the specialized management for females of reproductive age, right? Because they can have fetal thrombocytopenia. Okay.
Mm.
Okay. So I may have the principles of management of ITP. I told it under main four domains. One thing was the patient education. Next one was the general measures. Then you had the pharmacological management and specialized management for females of childbearing age. Are you there?
Yeah.
Right. And then I mentioned about Dapsone. Can you remember?
Yeah.
So dapsone is given only for chronic ITP, right? It is because it has some anti-inflammatory properties. Therefore, you give it only for chronic ITP. You don't give it there. And yeah, and uh, and platelet transfusions are also like it is done for acute life-threatening hemorrhages, right? It is not done routinely. And there is a place for rituximab, right? Rituximab also there is a place. Uh, Yeah, those are the basic steps in management of ITP.
Okay.
Any question?
See, one more time. The four main components are patient education, general
Yeah,
measures, which have five components,
yeah.
pharmacological management, and fourth one is specialized management for pregnant women.
No, females of childbearing,
Okay, females of childbearing.
right?
Yes.
Okay, no.
Do we have to know in detail about this as well? Females of childbearing age?
No, 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 no. This is PED, no?
Yeah, okay, okay. And also, Siri, if platelet count is less than 20,000, then do we need to know about the management of that?
Uh, yeah, you need to admit the child, right? So
Yeah.
then after admitting the child, um, one thing, so that is again a specialized management. Wait,
Okay.
let me check whether I have a note. If the platelet count is less than 20,000, you like depending on the symptoms, you can treat like if it is very urgent, you can go for IG, and immunoglobulin,
Mm-hmm.
those kind of things. I'm not actually sure. Mm, platelet transfusion, of course, like unless that's a life-threatening hemorrhage, they don't do, right?
Mm-hmm.
So they can start the patient immediately on prednisolone, right?
Mm-hmm.
And after admission, and if the patient is acutely like unresponsive to prednisolone, refractory, you can try the other measures like rituximab. Even this TPO receptor agonist are there like L-trombopac. You can give L-trombopac.
Mm-hmm.
Hema, I don't think they will ask what
Yeah.
to do next. Hema Kela, like you can, it's basically the steroids, right? Steroids,
Mm.
oral prednisolone, methyl prednisolone. Those things are the ones, right?
Okay.
Anything else?
That's about it.
Okay, ne? Okay, okay.
Thank
Tika,
you,
you are right.
Mark.
Thank you, Siri.
Thank you.